How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA. We're all made of the same.
Hi, you're listening to DNA Today, a podcast and radio show where we discover new advances in the world of genetics. From genetic technology like CRISPR to rare diseases to new research, we have you covered. For a decade, DNA Today has brought you the voices of leaders in genetics. I'm Keira Deneen. I'm a certified genetic counselor and your host. Surely you've heard of whole genome sequencing, but what about rapid and ultra-rapid whole genome sequencing? This is an emerging method of diagnosing genetic conditions for quick management. PerkinElmer Genomics offers this incredibly valuable test, which can be life-saving for ill babies and kids. Learn more in our full episode with PerkinElmer Genomics on here, DNA Today. You can visit PerkinElmerGenomics.com for more information. The link is also available in the show notes and on our website, DNAtoday.com. Did you know up to 75% of all cancer drugs will not work for a specific person because of their unique genetic profile? And half of these people who are resistant to a drug have a known mutation or pathogenic variant. That's why pharmacogenomic testing is key. TruGene Diagnostic offers detailed pharmacogenomic testing so drugs can be personalized based on someone's genetic predispositions. TruGene Diagnostic maps out millions of data points to know the best matched drug per patient based on resistance and, for the first time in history, sensitivity. For patients with HER2-positive cancer, it's vital to start drugs that have the best chance of effectively fighting the cancer. By doing so, it drastically increases the patient's chance for survival. Stay tuned for an upcoming episode featuring an interview with the founder of TruGene Diagnostics, who dives into the data with me. In the meantime, check them out at TruGeneDiagnostics.com. Again, that's TruGeneDiagnostics.com. Last episode, we learned about non-invasive prenatal testing, NIPT, for recessive conditions through BillionToOne's Unity screen. Jen Hoskovec is back for this episode where we are exploring NIPT for fetal antigens this time, which I know less about, so I'm very excited for this. For those that haven't listened to that last episode, Jen is BillionToOne's Senior Director of Medical Affairs, and I really do recommend for everyone to listen to that episode before this one because I think there's going to be a really nice segue between the two. We recorded them in that order so that you could listen to it in that order. And again, we were talking about NIPT for recessive conditions, but Jen, for those that aren't going to hit the pause button because, you know, their hands are soapy with water because they're washing dishes, they're doing whatever, they're in the car, could you give us a quick refresher of what NIPT is?
Absolutely. Yeah, thanks for having me. So NIPT, most people are familiar with NIPT as a technology that's used to screen for fetal aneuploidy, like Down syndrome and similar conditions. And we are taking the same idea, but tweaking the technology a bit and looking at cell-free DNA, which is free-floating DNA in the mother's bloodstream, and using sequencing as well as some molecular counting, so a bit of a novel technology, to assess the likelihood that the baby has inherited two variants from the same gene, like cystic fibrosis or sickle cell disease, and is at high risk to be affected with the condition.
It is impressive how far NIPT has come in the last 10 years, because it's 2011, 2012. I can never remember which one it is. What year was it clinically available? Do you remember?
Yeah, 2011.
2011. All right, I got to get it into my head. Maybe that's why I get confused, because it was the end of the year. I also wasn't practicing yet. This show had just started. But yeah, so it's interesting because, you know, as you were referencing, we started with chromosomal conditions like Down syndrome, trisomy 13, 18 sex chromosomes. But it's really interesting that now we're starting to use it, and really you guys seem to be the leaders in the market in terms of looking at it for recessive conditions. I haven't heard of another company doing that. Listeners, email in, but I'm pretty sure they're the only ones doing it. But we're kind of focusing today, as we're continuing this kind of part 2 of our conversation, but we're focused on BillionToOne's launch of an antigen version of NIPT in the fall of 2022, right? It was end of last year.
Yes,
Okay.
just this past fall.
Yeah. So provide us some background. I mean, I want to start with just what are antigens, and then we can kind of build up to like exactly how this test works, who it's useful for those that are kind of going back to biology or maybe haven't taken biology yet, depending on ages listening. What are antigens?
Yeah. So If you think about during pregnancy, some of the common testing or screening that is done early in pregnancy, we'll start with RH, right? So everyone gets a blood type and we call it a type N screen. So your blood type is either A, B, ABO, and then there's a positive or negative at the end. And that's for what we call RHD, right? So women, for example, or pregnant patients who are RH negative, means that they don't have this antigen. And what happens is if their pregnancy is RH positive, right, and there's mixing of that blood, their body recognizes this RH antigen, D antigen as foreign, right? And they develop antibodies, right, which is a natural response to a foreign body in the bloodstream. And unfortunately, what that then means is those antibodies could attack the baby's blood cells, right? And the baby can then become anemic. And that whole process could result in a condition we call HDFN, or hemolytic disease of the fetus in the newborn, which can be very, very severe and impact the quality of life for the baby, or even result in fetal death. So RHD, we know now that for pregnant women who are RH negative, you can give them RhoGAM, right? So this is very commonly known, and you can give them RhoGAM, which kind of blocks that interaction in the development of the antibodies. But there are other fetal antigens where we don't have a treatment like RhoGAM. And that is where, if you work in an MFM clinic, you might have seen patients who we call are alloimmunized to specific fetal antigens. And ultimately what happens is if they have a positive antibody screen, meaning their body is producing antibodies to a particular red blood cell antigen, there is the possibility that they are at risk to have HDFN in the pregnancy, right? So what we need to then know is, how do we figure out if they're really at risk? What's going on with that baby? Is the baby antigen positive or antigen negative? That's the big missing piece, and that's the big question.
So the main antigen that you're looking at is that common one, like my blood type is O positive. So for me in the future when I'm pregnant, I don't have to worry about this because it's people that are negative that are pregnant. I'm getting that right?
That's a great, yes and no. So yes, for RHD, you are D positive. So you would not be at risk to have alloimmunization or HDFN related to RHD. However, there are many antigens, right? So early in pregnancy, in addition to blood typing, you get a screen, an antibody screen, and it screens for a bunch of these antigens, right? So some of the common ones you hear about are KEL, little c, big C, Duffy. So we screen all pregnant patients for these antigens. And if it's negative, you move right along. But if it's positive, if you have a positive antibody screen for one of those antigens, what that then means is that there is the potential that you are at risk to have HDFN during the pregnancy, because you are what we call alloimmunized. Your body is creating these antibodies, so you are automatically negative for that. Does that make sense?
Interesting. Yeah, definitely. I've seen that in patients' charts because I don't order those tests. That's more in the nursing department. But when I'm looking for my own results, I'm like looking through it. So I think that's a lot of that's kind of your first prenatal blood test. Like for us, they meet with the lead nurse practitioner and then she orders like lots and lots of vials. So I think that's included in what you're talking about.
Exactly.
Which is kind of their first big appointment after we have like a positive blood pregnancy test, looking at HCG levels, and then we do an ultrasound, and then that's kind of the next real consultation where we sit down. So It is important to learn early on. So yeah, that makes sense. So through Unity then, so you're able to look at a few of these, or you're focused on just D that we were talking about?
Great question. So initially it was just D. Initially we offered fetal detection of RHD, right? And that can be useful even if a patient doesn't have antibodies, right? Even if they're not alloimmunized, perhaps they just want to know, if I'm Rh negative and my baby is Rh negative, RhoGAM isn't necessary.
That's huge. I think that's such a key point to pull right now. Yeah.
Right. And it's still standard of care in the US. And I do think as more data comes out, providers will likely become much more comfortable in making RhoGAM optional, or perhaps recommending not to give RhoGAM in the presence of an Rh negative pregnant patient and an Rh negative fetus via cell-free DNA. It's very commonly used in Europe to determine who gets RhoGAM, right? Because they have a shortage of RhoGAM in Europe. And so they have to find a way to determine who really needs it and only give it to the patients who have Rh positive cell-free DNA tests. So this is kind of a new approach in the US, but has been very commonly used in Europe for many years.
Interesting. Sometimes I see that the other way around. We're leading something and then Europe. So it's interesting to hear that in that direction. So if you have a pregnant person that's negative, and we have the father of the baby, the sperm donor, and we know that they're negative, are we good because baby has to be negative?
Yes, exactly right. So it is recessive, right? All of these antigens are recessively inherited. So if you are confident about paternity,
that was the other thing I was going to mention. Now, maternity is definitely an aspect to this, which is why I imagine so many people end up getting ROGAM, because we're like, rather be on the safe side. Yeah,
exactly. So you could combine what you know about the pregnant patient's partner as well as cell-free DNA. That gives you as much information to use to make the decision about something like ROGAM. The trick is, for all of these other antigens, you don't know your status unless you actually do genotyping, right? And no one just goes and does genotyping to see what your antigen status is for these various red blood cell antigens.
And if I haven't done it, then other people are doing it.
Right? Exactly. So you would only know if you're negative. Let's use KEL. That's a very common example. So if you're KEL negative, you would only know if you have antibodies, right? You could be KEL negative and not have antibodies, but if you have antibodies, then we know you're KEL negative and you're what we call alloimmunized. In some way, shape, or form, you've been exposed to KEL positive, maybe a blood transfusion or something along those lines, perhaps a miscarriage previously, something like that. So there's two things that you can do at that point. The first is you could test partner, right? So if partner is also KEL negative, homozygous negative, then you know that that baby is negative, right? If the partner is homozygous positive, right, for the via genotyping, then you know that baby will be positive.
Because they can only, they have two copies of that positive. They can only pass down a positive. Yes.
Exactly. Okay. So the baby would be heterozygous, but would be positive.
Right? One from each parent. Yep. Okay.
Exactly. Now, if the partner is heterozygous, we don't know. It's 50-50, right? And that is where, even if you have partner testing, cell-free DNA can come in handy versus doing something like an amniocentesis, right? Which would be the only other way to determine the baby's genotype. So cell-free DNA can help for patients in which they're negative for one of these fetal antigens and the partner is heterozygous, or in the case where we don't know partner status, which is a large percentage.
Right?
Exactly.
Yeah,
we don't know status.
Cases.
Same thing we talked about in the last episode, right? Of maybe not knowing if the partner is a carrier of sickle cell disease or cystic fibrosis. So this allows us to identify fetal status in the absence of knowing partner's information or in the presence of the partner being heterozygous. Once we know baby status, we can then streamline the patient's monitoring, and we can talk about what that looks like.
Yeah, so let's get into that. So we've talked about ROGAM and times that that's administered. Maybe we'll mention that before we get into monitoring. So I know for what I'm involved in, when someone has an amnio or a CVS where there could be blood mixing, they are given ROGAM if they're negative.
Correct.
What are other times that a person that's negative, where we think that they could be at risk for this, would get ROGAM? Like, I'm thinking delivery, like that's probably mixing. Are there other things I'm forgetting?
So routinely, patients get ROGAM midway through the pregnancy and at delivery if they're Rh negative. Now, if they have a procedure like a CVS, an amniocentesis, yes. They may actually also get ROGAM if they have some sort of accident or there's, evidence of a maternal fetal bleed. Now, if the patient's alloimmunized, though, meaning they're Rh
actively
negative,
happening,
but they have antibodies present, ROGAM is no longer helpful. So at that point, those patients are alloimmunized to RHD. So if you have a positive antibody screen for any of those red blood cell antigens, even something like a ROGAM for RHD is not useful, and we have to monitor those pregnancies because they could be at risk for HDFN. So what that looks like is a couple of things. You could, they do blood titers. So they draw their blood and they monitor these titers. And when those antibody titers reach a certain level, it's like a critical level and it's different per antibody. At that point, they move on to the next step of monitoring. Okay. So if they remain low and they don't reach that critical level, They just are monitoring their titers, and they never have to do anything else. But
And do
if
you
they
think
reach
that's like a weekly basis to like check in, or like once a month? Like I'm
yeah,
thinking
I
at a
think it
certain point, it's every
depends.
2 weeks patients come in, so I could see them just adding that on to the appointment.
Yeah, 2 to 4 weeks typically to monitor those titers. And then if they reach a critical level, that's when you move into the ultrasound monitoring with what we call MCA Dopplers, right? So looking for evidence of fetal anemia, right? And you do those every 2 weeks. You can imagine the intensive resources that are required for routine blood draws, routine ultrasounds, serial ultrasounds. And imagine coming in to have an ultrasound every time, hoping that you don't see that your baby is sick or is
Just
anemic,
the anxiety,
right? It's
like
stressful.
every time you have it and then you go home and you're like, well, I'm coming back in X amount of weeks to just do it all over again. Like that's very anxiety provoking.
Exactly. And then worst case scenario, if we have evidence of fetal anemia and it comes to the point where they recommend fetal intervention, at that point, you're talking about a fetal blood transfusion, right? To manage the anemia. So
and that's pretty involved. Like I haven't yet been
yes.
involved in a case with that, but just from hearing things at different conferences, that's not something that you can just do probably at your local hospital. Do you have to go to like a center or something, or?
Yeah, so there would need to be a maternal fetal medicine specialist who is trained and comfortable doing these transfusions, right? And so that's where MFM is very heavily involved in monitoring these patients. Typically, alloimmunized patients are moved from a general OB setting to being monitored by maternal fetal medicine for that reason, right?
And so a lot of this screening, like you're looking to see, okay, is the fetus developing? Like, are we okay? Is blood flow okay? Like, we're not seeing anemia. Is there risk for the pregnant person, kind of like on the other side of it, or is it's more focused on the pregnancy?
It's more focused on the pregnancy and the health of the fetus.
If you've been listening to DNA Today for a while, you probably know I'm also a full-time prenatal genetic counselor. Between that job, this podcast, and being a producer, host of other podcasts, I'm pretty busy. So to keep up my energy and stay productive, I drink a decent amount of coffee. Think like Lorelai Gilmore, but maybe not quite that much. The new coffee I'm drinking is from Four Sigmatic, and I'm really picky about my coffee. It's got to be bold, not watery. That is the worst. I still drink it if I have to, but it's not my favorite. And I have to say, I've been really happy with Four Sigmatic. Here's the difference from other coffees. It includes mushrooms, which I know sounds bizarre. I will admit I was hesitant, but you don't taste the mushroom at all, and you get the health benefits from it. I like the immune system boost as I often get sick in the winter months, so this is really important. And I wanted to team up with Four Sigmatic to get you 30% off using promo code DNA Today, and you can redeem it at foursigmatic.com. Again, that's four, spell it out, F-O-U-R, Sigmatic, S-I-G-M-A-T-I-C.com. Use code DNA Today for 30% off, and let me know if you like it too.
Which drug do you prescribe for your HER2-positive cancer patients? For the first time in history, True Gene Diagnostics informs you which of the 3 leading cancer drugs your patient is sensitive to and resistant to. True Gene Diagnostic knows the functional effect of every mutation in the TK region of HER2 gene and knows the functional effect with and without the 3 most common drugs present, thus allowing you to match the best drug to the patient. Unlock the best drug for your patients with HER2-positive cancer using True Gene Diagnostics. Check it out at truegenediagnostics.com. Oh, and stay tuned for our interview with them. Genetic technology moves fast. The first genome took 13 years to finish a draft. For reference, this was 20 years ago in 2003. And now, a whole genome sequence can be performed in days, even hours. Since sequencing an entire genome can be done in such a short amount of time, this lowers the cost, which means more people can utilize whole genome sequencing now. This is particularly helpful in the NICU for ill infants. PerkinElmer Genomics explained more to me in our full episode here on DNA Today. It is remarkable how quick diagnosis from whole genome sequencing can save a baby's life with a change in treatment informed from the results of that test. I learned more about how genome data is mined to maximize useful information from one data set and other omic assays that help enhance diagnosis. Don't miss the full episode here on DNA Today. You can visit PerkinElmerGenomics.com for more information. The link is also available in the show notes and on our website, DNAtoday.com.
Now, imagine doing all of that but the baby's fetal antigen negative the whole time. Right?
That's and so then you find out at the end, like everything you did, you didn't have to do.
Right. And of course we do it to be on the safe side,
of
right?
Course,
because severe fetal anemia is a very scary place to be for those families, right? And we've heard these really devastating stories of patients losing their pregnancies to HDFN. So it's a very severe disease. But if we can identify with accuracy which patients are truly at risk for HDFN based on genotyping information, based on cell-free DNA, then we can really streamline that and personalize that management for patients and not put patients through all of that if it's unnecessary, and ensure that if it is necessary, that we're not missing those appointments, that we're staying on top of it, right? And that we are taking care of those patients appropriately.
Yeah, I mean, that changes completely management, because if someone finds out their fetus is also negative, as you said, everything we just talked about, the different levels of like, okay, looking at the blood test, now we're doing the ultrasound, serial ultrasound screenings, and then, okay, now we've gotten to the point where we need a transfusion. Like, obviously not everyone's going to get to that point, but all of that being involved could possibly be eliminated by doing this blood test, the Unity blood test.
And knowing fetal status. Yeah, exactly. Right. And so we're able to do this currently if a patient is alloimmunized or has a positive antibody screen for D, RHD, right? For little c, big C, big E, Kell, and Duffy.
That's a longer list than I thought you were going to say. I purposely didn't research too much because I wanted to authentically learn in the moment. But that's much longer than I thought it would be, especially because you launched not too long ago.
Yeah. Yeah. And, you know, the interesting thing about this is it's a relatively straightforward use of the technology. So let's use Kell for an example. Okay, because that's probably it's the most common one. We've currently, if I looked at the first 200 samples that we ran, the first 200 patients, and 35% of those, it was Kell, was what was ordered, right? But over 80% of those babies were Kell negative.
Wow.
And that's what we expect based on genotype, based on the prevalence of these genotypes. Now, there is one single nucleotide change in the Kell gene that results in Kell antigen presence. So if a pregnant patient is negative, she has antibodies, right? We know that she's negative and does not have the variant, right? So if we look in the cell-free DNA and we see that variant, we know that it's in the fetal cell-free DNA and the baby has it, right?
Right. You can rule out it's not the pregnant person. It has to be the baby because we've already established the pregnant person's negative.
Is alloimmunized. Right. She has antibodies, which inherently means she's negative. But other thing that we do, we take it a step further. So that's the detection of the variant, right? It's present in the cell-free DNA. We know it's not in mom, so it must be in baby. But we take it a step further because you have to be certain as you can be, right, with a cell-free DNA test. You have to have very high sensitivity because you're making medical management decisions with this information. And so if you think about a fetal fraction, right, you would expect the amount of variant in the blood sample to match your fetal fraction, right? Because
all comes down to statistics.
Yep, it's coming from the pregnant patient's partner and it's in baby. So you have an expected number of molecules, right, in that sample based on the fetal fraction that you would expect to see the variant in, and when you observe it, it should be 100%. So if your fetal fraction is 10%, that's what you should see in terms of the percentage of molecules with the variant, right? Now, if we saw 50%,
though, yeah, like let's say your fetal fraction is 10%. If they're hetero, would you see 5%?
No, because the fetal fraction that we're looking at is really paternal allele, the paternal SNPs.
Oh,
right?
That's a good point.
So it's fully, yeah. It's actually a good question. I get that question a lot. And as soon as we say it, we're all like, oh, yeah.
Right. Now I feel like it's a stupid question, but someone else was thinking it listening.
Oh, I've been asked that question a lot.
Yeah, good. It's on your FAQ list. Great.
Yeah.
Yeah, no, that's interesting.
So that's how the technology works. So it's actually really straightforward because it's a little bit different from, say, sickle cell disease, right? Where mom herself actually carries the variant of interest, right? Here, She does not.
It is
So
more
it makes
streamlined.
it is much more, it's kind of a more obvious assay and a more obvious use of the technology, which also allows us to kind of show why we're so confident in those results. Like when we see it and we say the baby is positive for that antigen, you can use that information. If we see zero signal, that means neither mom or baby has that variant, as long as we have, you know, our appropriate fetal fraction and everything like that in terms of the assay.
So if you have, let's take that case you just said, where you're not identifying anything, so you're like, okay, baby must be negative. How common is it? Because this is considered a screening. So just like all the NIPT, NIPS, however you want to call it. So what is the chance that you don't pick it up in the sample and it turns out baby actually does have it? It sounds like that would be pretty rare. Like when we look at that for other conditions like Down syndrome, most labs would say now there's a 1 in 10,000 risk that we miss this condition. Right.
So to date, all of our validation has been 100%.
Wow.
Right. Now there's a variety of ways you validate, right? You use preclinical samples. So you're basically sharing parent-child DNA pairs to mimic pregnancy with known outcomes. You then look at clinical samples.
That's an interesting approach. I wouldn't have
It's
thought
cool.
of that. Yeah, that is cool.
Yeah, it's actually a very common approach for these like rare genetic conditions. And then there's clinical samples that you look at, and then certainly newborn outcomes, right? So one of the things that we're doing is we're running these tests, and then we're enrolling patients in a registry, those who are interested in participating, enrolling patients in a registry, and then genotyping those babies at birth to confirm what we're seeing. Because you can imagine something like RHD. If you're Rh negative, your baby's going to be typed and screened at birth. We'll know that. But
that's
for
from
Kel,
the heel prick test, right? It's just part of newborn screening.
They test for Rh negative moms. Not every state does it if you're not Rh negative. So not every baby gets blood typed at birth in every state.
That's surprising.
But for something like, I know it surprised me as well. But for something like Kel or C, there is no clinical indication to know a person's status, even if the patient's alloimmunized. So they just treat the baby at delivery if the baby has any symptoms of anemia and they move on. So we have to proactively collect a sample, cord blood, buccal swab, and then send that baby's testing to a third-party lab, get the genotype, and then correlate it back to our test result. So that's a registry that's currently going on. And thus far, the ones that we have done, relatively small number though, but have been 100%, as we would expect.
That's awesome. So I'm thinking to compare it, like if I have a case where through NIPS, we've identified a high chance for Down syndrome, that person decides to do an amnio, or that person decides to have the baby and then test afterwards. And basically we get a definitive Down syndrome diagnosis. A lot of times the labs will send me a fax because we're living in the 90s, and they'll be like, oh, did that end up happening? Were you able to confirm that Down syndrome? So is that a similar setup, or because of this registry, you're not really reaching out to the healthcare providers that ordered it?
We're not, because they're not ordering a test to confirm it. That's the problem. So that
ends
would
up
work
being
very
later.
well.
It's not the prenatal people ordering that.
Well, and there's no test, right? So for example, sickle cell, we can absolutely do that. We can call the provider, we can call the patient, say, did your baby pass the newborn screen? And then we know if that baby has sickle cell or not. For antigens other than D, there is no routine screening at delivery. There is no confirmation of baby status at delivery, because it's not clinically necessary for the health and monitoring of that baby, which is why we would either have to encourage a provider to order that just out of the goodness of their heart to make sure this was all correct, or we have to create the study ourselves to ensure we're getting those outcomes. So that's why you will know if a baby has Down syndrome at some point, right? You would never know a baby's Kel status unless you looked for it.
Yeah, or like 30 years later and they're pregnant or something. And the study can't go that long, at least. Yeah, I'm sure it will someday. But
so there, it is a bit of a unique, in speaking with genetic counselors, there are some genetic counselors who are more heavily involved in this in their clinics because they're MFNs, involve genetic counselors in the counseling of patients with alloimmunization, kind of helping them understand the recessive nature, right? Because it is genetically inherited, or to talk about amniocentesis, because that's the alternative, right, is you could always, if you're alloimmunized, have an amnio and know the status of your baby. What we recognize, though,
to go through an amniocentesis, it's not simple.
It's a big decision. And it's also, to a point contraindicated, right? Because there is inherently a mixing of blood at that
I was going to say, you're mixing blood to find out if blood should not be mixed. So it's kind of, I can see that.
So, I do recognize that there are patients who will have an amnio for purposes of that. But if you can avoid that and have confident information to make medical management decisions, or at a minimum counsel your patients about the potential to minimize the monitoring or pull back on the monitoring given the baby status, I think it's going to be a game changer. I think it's just going to take a little time for people to really see the data come to fruition and be comfortable. But we've had a lot of excitement, particularly with MFMs, about this option.
Yeah, because they're your target audience here. I think genetic counselors can be involved and go to their OBGYNs, MFMs, and say, hey, I think this is really useful. But I would say, your number one person ordering this may not be a genetic counselor, which is also kind of interesting because, as we're talking about, it is genetic, but it's not something that, this wasn't ingrained in me in grad school. I'm sure there's lectures where it was mentioned, and the further I get away from grad school, the less I remember. So, I think that's part of it. From a logistics standpoint, though, for those listening that are healthcare providers, which is the majority of our audience, so is there a minimum gestational week that we can order this? I kind of want to know some of that aspect of straight up ordering the test.
It's the same as any cell-free DNA test for us. So it's 10 weeks and 0 days. Mm-hmm.
Okay. So that's the minimum.
Yeah.
And then, so let's say they want to order Unity for recessive conditions, antigen, and just normal NIPT, NIPS, looking for sex of baby, Down syndrome, the other conditions. I mean, that's a lot. That's kind of 3 tests in one. So how does that work? Do you have to pull multiple Tiger top tubes? It's
a great question. So the way we have this set up is we basically have two main buckets. So we have our carrier screen, which we talked about on the last episode, right? The carrier screen with the reflex to single gene, that's ordered. And then this fetal antigen assay, including just the RHD for your Rh negative patients, even if they're not alloimmunized, even if they just want to know baby status, that actually is built into our aneuploidy assay. So this is a unique piece. Yes, for a couple of reasons. The first reason being, it is really essential to have a robust fetal fraction, right? We talked about that you have an observed amount of the signal that you're looking for. We need to see that matching. You need to ensure that we have an appropriate fetal fraction. And so a robust fetal fraction that you're doing for something like aneuploidy is extremely helpful. The other is that if you think about alloimmunization in pregnant patients, it's about 1% of patients. It is not overly common, right? Which is another reason I think we may hear about it in a clinic, and then you won't hear about it for another 6 months. And then the MFM will come back and say, oh, I've got another patient with KEL. Does this exist yet? Right? Because it's not every single day. And if you think about that, and even with RHD, about 15% of individuals are Rh negative, right? So the vast majority of people are Rh positive.
Yeah. So most people you talk to, they say their blood type, O positive, is that the most common or something? I think I'm just boring most positive. Yeah. Most common.
Me too. So
that's what American Red Cross told me, at least when I go to donate. Yeah, so
exactly. Yeah. So the other reason is that if you're using this information for medical management, you need it quickly, right? And if it's ordered relatively infrequently, right? You've got to be able to have a way to run it very quickly and report it very quickly and make it affordable, right? So for a test that is done on a small percentage of the population, if you can build it into a routine test that is run every day in the laboratory, it allows you to make it much more accessible, much more affordable, and much quicker.
Wow,
right?
You guys have thought through everything. That totally makes sense. And then I'm sure that also helps with all your validation, because then you end up having so many more samples that then you can be using for your N number for your different studies and everything.
Right. The other thing it helps with is, let's say an OBGYN orders this, right? Orders just routine aneuploidy. And then they get her blood test back, 2 weeks later, and they're like, oh, she has a positive antibody screen for KEL. It's always run in the background because it's built in the aneuploidy test, right? So it's a phone call to us to say, hey, I now need this for this patient. We don't need another blood draw.
Wow.
We don't need another order. We literally unblind the data, analyze it, and issue a new report with the KEL information.
So the new report would have aneuploidies, Down syndrome, all that, and then it would just have like an extra information with like this information.
Yep, with the KEL.
Mm-hmm. That's
now that
awesome.
now that you know that you need that piece. So
Right.
It's run in the background. It's as part of the assay, but it's only analyzed and reported if it's ordered.
Wow. So that is, I mean, because I was going to ask about turnaround time, but it's just going to be your normal NIPS turnaround time, which I imagine is probably, 7 to 14 days like everybody else?
Yeah.
Or 7 to 10, I should say.
Actually, 7 to 10, I would say we're running closer to 5 to 7 days most times at this point. So it really can be taken and utilized, and incorporated into counseling and medical management very quickly.
Wow.
For these families.
Very cool. Well, thank you so much. I mean, I'm just like so shocked. You're so well spoken. You use like no filler words. As someone that is constantly interviewing people, like I pick on people's filler words pretty quickly. Listeners probably know mine is like kind of, and how many times have I said wow in this episode? But anyway, you're so well spoken. I just love nerding out with you about this because we just sit down and we chat and I'm like, oh yeah, should I look at our episode outline? What questions am I supposed to ask? I'm just like, oh wow, a half hour went by. Hopefully we covered everything. But thank you so much, Jen.
It's been
this
so
is
much
cool.
fun. I really enjoy it. You're doing really great things here, and it's been a really fun experience. So I'll nerd out with you anytime.
Sounds awesome.
For more information about today's episode, visit dnapodcast.com, where you can also stream all episodes of the show. We encourage your questions, comments, guest pitches, and ideas. Send them all into info@dnapodcast.com. Search DNA Today on Twitter, Instagram, YouTube, Facebook, so you can connect with us there. And a favor, please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allow more genetic nerds like yourself to find the show. DNA Today is hosted and produced by myself, Keir Deneen. Our social media lead is Corinne Merlino. Our video lead is Amanda Andrioli. Thanks for listening, and join us next time to discover new advances in the world of genetics.
The genes of you and me, the genes of you and me are all made of DNA. We're all made of the same chemical DNA. We're all made